All right, hello everyone. We will get started right now. Thank you all so much for being here today. My name is Tayaba Khan and I work for the Spartan Center as program manager. Thank you for being here today. To hear Dr. Courtney Sullivan talk about her work in pediatric oncology. Today is also International Women's Day, so I see all these wonderful women right here, so thank you all. And I'm just going to do a little introduction for her. So Dr. Courtney Sullivan is a postdoctoral research fellow in UAB, where her research focuses on measuring pediatric oncology, nursing quality, and establishing an evidence base of nursing-sensitive outcomes internationally. She attained her Bachelor of Science in Nursing from Michigan State University and earned both her master's degree as an acute and continuing care pediatric nurse practitioner and PhD in nursing from UAB. Her passion and focus are to support and enable nurses to improve practice and outcomes. Dr. Sullivan has worked with nurses internationally through St. Jude Global and other avenues for nearly a decade. She established the Latin American Nurse Educator Network, St. Jude Viva Asia Pacific Nursing Institute, and co-led the development of the Associate of Pediatric Hematology and Oncology Nurses Spanish Chemobiotherapy Certificate courses in Latin America and laid the groundwork for Portuguese and Russian versions. Presently, she is the SIOP Nursing Network Chair. SIOP is the International Society of Pediatric Oncology. Dr. Sullivan is also engaged in the WHO Global Initiative for Childhood Cancer and is passionate about integrating nursing priorities within National Childhood Cancer Control Planning. And with that, without further ado, I would like to give the floor to her. Thanks so much.
Okay, make sure that you can hear me because my voice is a little bit soft. Thank you, Tayaba, and thank you everyone at Sparkman for having me here today. Today, it is my great pleasure to share with you about a subspecialty in global health, and that is global pediatric oncology and nursing. The title of my presentation is Tell Someone I Am Here, Giving Voice to Children with Cancer and the Nurses who care for them around the world. Nelson Mandela said it well when he said, "Our children are the rock on which our future will be built. Our greatest asset as a nation. They will be the leaders of our country, the creators of our national wealth, those who care for and protect our people." In 2022, 134 million children were born around the world. At the current rate, 2.3 million of these are expected to die in the first 28 days of life. And an additional 2.7 million won't make it past their 5th birthdays. This represents 5 million children under the age of 5 whose deaths are mostly preventable. Over the past 20 years, significant progress has been made in reducing under 5 mortality from nearly 10 million in 2000 to 5 million in 2020. However, large disparities remain between regions, countries, and within countries. Globally, infectious diseases and perinatal complications are the leading causes of under 5 mortality and have received the greatest attention. In an effort to adopt a more holistic child health agenda, the 2016-2030 Global Strategy for Women, Children's, and Adolescents' Health recognizes the importance of addressing emerging child health priorities of non-communicable diseases, including childhood cancer. Of the 429,000 estimated new cases of childhood cancer each year, 89% live in low and middle income countries. In high-income countries, survival rates average under 30%. Or in high-income countries, survival rates average greater than 80%. And in low and middle-income countries, survival rates average under 30%. To address this gap, the WHO launched the Global Initiative for Childhood Cancer to increase survival rates to 60% globally and reduce suffering in children by 2030. I'd like to share with you a 5-minute documentary titled How I Live by Persistent Productions. This will show you from the experiences of patients and families internationally, what it's like to live with cancer. Okay, now does everyone see this on Zoom? Hopefully. Okay. I'm gonna stop sharing and then just reshare just to make sure.
Childhood cancers are one of those diseases where we really can make progress. It's a set of diseases that kills disproportionately people in low and middle income countries. A child is born in a high income country, it has an 80% chance of surviving cancer today. If it's born in a poor country, it's 20%. And this is because diagnosis is lacking, because access to medicines is lacking, just awareness is lacking that actually something can be done about it. That's what we want to change. And that's why now.
This is so peaceful, assuming what is happening. Like she just walked in, sat in the chair, and looked at me, and like she was paying attention, even though she doesn't speak English, right? So the question is how to keep them here, how to get the chemotherapy on board, how to do the radiation, shorten the treatment as much as possible, and hopefully we cure her.
The eye surgeon is planning to do biopsy tomorrow. I think it is sarcoma, most probably that they are sarcoma.
The US or in Europe, she would have a 95% plus, close to 100% chance of cure. So you want to get as close as that as possible. As long as that they live 2 days away, right? So the abandonment risk is very high.
Some who are talking.
Empezó en un partido que tenía de fútbol, que me golpearon aquí y lo vimos como un simple morete, un golpe, y de ahí fui al siguiente día al colegio, y cuando yo empezaba a entrenar fútbol y todo, me empezaba a cansar bien rápido, lo empezaba a hacer, no podía correr mucho. Primero entré al hospital privado al diagnóstico y primero creímos que era una neumonía. Me empezaron a hacer exámenes, me vieron aquí para sacarme agua y cuando vieron tenía un tumor.
Was it difficult to hear the news about the diagnosis?
Sí, por todos los deportes y todo eso. Me enferma.
Working been really strong during treatment.
Sí. Continúo con todas las quimios todos los lunes. Me faltan como alrededor de 20 quimios.
You know, a child is a child, no matter in the world they are.
family is a family. When your child has cancer, that child has the right to treatment, whether they live in Myanmar or they live in Cambridge, Massachusetts.
It's imperative. We don't want to let children die from causes that we can cure. And we know that treatment is possible.
Okay, bear with me while I get my screen to share again. All right. So as described in this video, the greatest indicator of cure for children with cancer is where they live in the world. Barriers to cure in low and middle income countries include lack of diagnosis, misdiagnosis, limited access to high quality and affordable cancer treatment, and socioeconomic and cultural barriers resulting in treatment abandonment. Furthermore, up to 80% of childhood cancers in low and middle income countries are diagnosed at the advanced stages. And often these children die in pain due to a lack of palliative care services and adequate pain management. Unlike adult cancers, childhood cancers are largely unpreventable and are not detectable through screening. Thus, early detection and referral of suspected cases are key to survival. Early diagnosis campaigns help to increase awareness of childhood cancer signs and symptoms at the community and primary care levels, while coordinated referral pathways are established between primary care providers and specialists to facilitate timely and appropriate diagnosis and treatment. Upon positive diagnosis, the child and family enter into treatment, which requires skilled multidisciplinary care to deliver disease-directed therapies, supportive care, and palliative care. Often, pediatric oncology units in limited resource nations are attempting to provide subspecialty care that is inherently demanding, complex, time-consuming, expensive, and requires a dedicated multidisciplinary team. While the government is dealing with competing priorities, political changes, budgetary constraints, and additional burden of non-communicable diseases. This is where local foundations and international partnerships can facilitate building sustainable pediatric cancer programs through training and education, prioritization of resources, building research capacity, and fostering a culture of care that is proactive and supports a team-based care approach. Partnerships in the form of twinning programs have been used in pediatric oncology since 1989, where traditionally more advanced centers help support pediatric cancer program development in limited resource settings. The first pediatric oncology partnership was established in 1986 at the height of the Nicaraguan Revolution, when the country was in shambles. I'd like to thank Dr. Carlos Rodriguez Galindo from St. Jude Global for sharing this story and slide with me. Dr. Fernando Silva, who is also a famous poet, was the director of the Children's Hospital in Managua, called Hospital Infantil La Mascota. Each day during his morning rounds, he would mark a cross next to the name of those children with cancer, so that the nurses and other ward personnel would know that there was little that they could do for them. You see, they did not have the resources to treat them. On Christmas Eve, 1986, he was making his evening rounds before heading home. A 6-year-old boy followed him and pulled at his coat. He turned around and recognized the boy from his morning rounds. He had been diagnosed with acute lymphoblastic leukemia, and Dr. Silva had marked a cross next to his name. The little boy was all alone. He had been orphaned by the war. He looked up at Dr. Silva and said, "Tell someone that I'm here." At that moment, Dr. Silva decided that he could no longer continue to mark crosses. He had to do something for children with cancer. Recently, a team from Italy had visited La Mascota. Dr. Silva reached out to his colleagues in Italy for help, and this began the first pediatric oncology training program. This collaboration, among others, led to the formation of the Central American Association of Pediatric Hematology Oncology, or HOPCA, a consortium of hospitals across Central America that develops and promotes shared protocols, training programs for nurses and physicians, and pediatric cancer registries. Today, AHOPCA is just one example of many pediatric cancer collaboratives around the world. Pediatric cancer officially became a global priority in September of 2018 with the launch of the WHO Global Initiative for Childhood Cancer at a UN side event in New York City, New York. And it was my honor to have attended this historic event. Objectives of the Global Initiative are to increase capacity of countries to provide quality services and to increase prioritization of childhood cancer at the global and national levels. The Curel framework supports governments and collaborators in building service capacity for childhood cancer within their countries. The Curel technical package recommends the development of centers of excellence and care networks with sufficient and competent workforces, universal health coverage with benefit packages and organizational models for quality services, regimens for management through context-appropriate guidance, technologies and medicines, and evaluation and monitoring with quality assurance and information systems such as cancer registries. Key drivers to support these efforts include advocacy, leverage financing, and linked policies and governance. The Curel elements work together to support coherent, comprehensive policies, access to and coverage of health services, and strengthening of health systems. In order to achieve the 2030 target and save 1 million children's lives, nursing must be strengthened and nursing priorities must be included at all levels impacting care. Now, nurses and midwives comprise the largest segment of the healthcare workforce globally and are responsible for delivering up to 90% of patient care services. Skilled and competent nursing care is essential for improved patient outcomes. Pediatric hematology oncology nurses care for children and adolescents with cancer and blood disorders across the care continuum, from diagnosis to survivorship or end of life. They provide care in the inpatient, outpatient, or community setting and support not only the child, but also their family and siblings with holistic patient and family-centered care. In the United States, pediatric oncology nursing became a formal specialty in the 1970s. Soon after, the Association of Pediatric Hematology Oncology Nurses was established, followed by standards of nursing practice, and in 1993, a specialty certification was developed for nurses, the Certified Pediatric Hematology Oncology Nurse, or CPHON, which endorses nurses' knowledge in the care of children and adolescents with cancer. In 2004, AFON established a standard certificate-based chemotherapy biotherapy course for nurses in the United States. In many nations across the world, pediatric hematology oncology is not recognized as a subspecialty. And although nurses and midwives represent the largest health workforce internationally, in countries with limited numbers of health workers, nurses may be assigned different tasks outside of the nursing scope of practice and be regularly rotated between units and hospitals. Although this generalist model provides staffing flexibility within health systems and hospitals, patients and families receiving care likely receive a lower quality of care. This is due to a lack of health workers' expertise and experience within complex specialties such as oncology. The evidence shows that specialization within nursing improves patient outcomes. Specialty nursing certification has been associated with decreased pressure injuries, falls, hospital-acquired infections, failure to rescue preventable deaths such as sepsis, and mortality. To ensure nurses are providing high-quality, evidence-based patient care, specialized education and certification is recommended throughout the nursing career continuum. In nursing school, upon entry into practice, professional development, through specialty certification, and on to advanced degrees. Within the global initiative, 5 working groups were formed with international multidisciplinary stakeholders to develop work products and toolkits aligned with the Curel framework. Out of the Positive Practice Environment Working Group, the nurse specialist of the Global Initiative for Childhood Cancer was established to elevate the nursing voice within the initiative. The nurse specialists of the GICC provide technical support and advice for WHO member states regarding pediatric oncology nursing policy and practice priorities. We have published 2 papers outlining priorities and strategies for strengthening the pediatric oncology nursing workforce, including recognition of pediatric oncology as a nursing specialty through non-rotation of nurses, adequate numbers of competent staff, and expanded roles such as advanced practice nursing and nurse scientists. Prioritization of national and facility level subspecialized nursing education across the continuum, as just shown. Adopting strategies for retention of specialized nurses through positive practice environments. Appropriate protective equipment, including PPE for handling hazardous drugs. And strengthening nursing leadership and childhood cancer services and the voice of nursing in decision-making. It is imperative that local nurse experts and leaders are given a seat at the table as key stakeholders in the initiative. In my experience, nursing is often discussed as a priority, but nursing representation may be missing. However, I do believe that the Global Initiative for Childhood Cancer has brought nurses to the forefront in cancer control planning, and that nurses are being included at the highest levels of discussion. To address barriers to providing quality care, the International Society of Pediatric Oncology Nursing in Developing Countries Nursing Working Group published baseline standards for pediatric oncology nursing in low and middle income countries. These standards outline minimum recommendations for safe pediatric oncology nursing practice environments in low and middle income countries. It includes staffing based on patient acuity, having a subspecialized orientation program for new nurses, ongoing continuing education, having nurses included in multidisciplinary care rounds, having adequate resources for safe care, including PPE for handling chemotherapy, and having evidence-based practice guided by nursing policies and procedures. We have a task force which is leading this initiative. And in 2016, we surveyed 101 pediatric oncology nurses from 54 countries to assess hospitals' adherence to the standards internationally. Across all 6 standards, the proportion of institutions that met the standards range from 12 to 66% for each of these standards, as you see in green here. The majority of hospitals surveyed were not currently meeting the baseline standards for pediatric oncology nursing, even some hospitals in high-income countries. Although there was a significant association between country income level and hospitals' achievement of the standards, overall nurses in low and middle income countries reported inadequate staffing levels, gaps in specialized training and education, limited inclusion of nurses in multidisciplinary patient rounds, limited resources for safe care, and an absence of essential nursing policies and procedures. Predictors of hospitals' non-achievement of the standards included low health expenditure, the WHO region of Africa, UN developing or transition country classification, countries with less than 3 nurses per 1,000 population, hospitals that did not have a bone marrow transplant unit, and hospitals without an ICU. These findings show significant gaps in pediatric oncology nursing standards in low and middle income and high income countries, representing priority areas for health policy and resource allocation. Recently, a framework was developed based on the baseline standards and nurse specialist publications for empowering pediatric oncology nursing and for recruiting and retaining the specialized workforce. Now, you may wonder how I ended up in global pediatric oncology nursing. So I'm going to shift gears and tell you a little bit about my story. I was inspired to become a nurse through several short-term international service trips, and my eyes were open to great need. I saw nursing as a practical way to help meet this need. I graduated with my Bachelor of Science in Nursing from Michigan State University and accepted my first nursing job at St. Jude Children's Research Hospital, a pediatric cancer hospital with an international outreach program and research focus. The 3 things that I have been looking for in an organization. I pursued my master's degree as a pediatric nurse practitioner to gain additional knowledge to apply in future international work. As I sought out NP jobs, a nursing coordinator position happened to come open at St. Jude's International Outreach Program. So I applied and I'm here today. For the next 8.5 years, I had the privilege of working with nurses all over the world, collaborating in the development of hospital-based subspecialty education programs, quality improvement projects, research and advocacy, and health policy initiatives. It was through my global nursing work that I identified my research interest of establishing quality measures for international pediatric oncology nursing practice and pursued my PhD at the UAB School of Nursing. Presently, I'm continuing my training as a T32 postdoctoral research fellowship through the UAB School of Medicine in the Fort. While at St. Jude Global, I helped to expand its nursing outreach from 12 to over 40 countries, transitioning from a twinning approach to a regional network approach. In Latin America, one of our pillar programs was the Latin American Center of Pediatric Oncology Nursing Education. This is a nurse educator training center in Santiago, Chile. This program pioneered the integration of pediatric oncology nurse educator roles and programs in pediatric hospitals across Latin America for the ongoing training and education of nurses. Graduates join the Latin American Nurse Educator Network, which impacts over 2,000 nurses within the region at any given time. In addition to education programs, network members implement collaborative quality improvement projects within their institutions, such as a multi-site positive patient identification QI project. I had the privilege of co-leading the development of the AFON Spanish Chemotherapy and Biotherapy course in Latin America, and this course has since been expanded in other languages and countries. In Eurasia, we established a working group of nurse leaders from 18 hospitals in 10 Eurasian countries, former CIS countries, as part of the Eurasian Alliance in Pediatric Oncology. This was the first time pediatric oncology nurse leaders in the region had been brought together in forming a collaborative group. And this is one of my proudest moments working with these nurses. In 2019, in collaboration with colleagues at the National University Hospital, NKK Women and Children's Hospital in Singapore, I also established the St. Jude Viva Asia Pacific Nursing Institute. This institute was modeled after the Latin American Center. However, it trains bedside nurses and nurse leaders across the Asia Pacific region. And we've had 2 cohorts so far from the Philippines and Vietnam. Through my international work, I identified my research focus, as mentioned, and the need for valid and reliable quality measures for international pediatric oncology nursing practice. In my dissertation study, a preliminary core set of nursing sensitive indicators and broader quality topics or constructs was identified by an international expert panel of 122 nurses from 43 countries. We have since reintroduced nurse staffing to the list as it was highly rated by expert panelists, and the association between nurse staffing and patient outcomes is well documented. In my current postdoctoral study, we are identifying measurable candidate NSIs reflecting each of the 11 quality topics for future pilot testing. And it's my goal that for these to become standard measures across hospitals internationally in low, middle, and high income settings all across the world, that we can come up with a set of standards where we can compare nursing measures, where we can establish a case of evidence for resources for hospital administrators and for those at the governmental level. In addition to my postdoctoral fellowship and research, I'm currently the chair of the SIOP Nursing Network, the International Society of Pediatric Oncology. And we have just established an exciting strategic plan for future growth and engagement opportunities for pediatric oncology nurses internationally. So raising up leaders, creating a platform and opportunities for people to get involved, to collaborate, and to do what they're interested in doing, what they're good at doing, and to receive support in establishing new initiatives. So in keeping with the title of today's presentation, I'd like to end with a couple of short videos. This is from the 20 Stories for 2020, Pediatric Oncology Nurses in the Year of the Nurse and the Midwife, and it was created by the SIOP Global Health Nursing Working Group leaders to chronicle pediatric oncology nurses' experiences around the world.
Being there to listen, to understand the concerns of children and parents, to educate them, to orient them, to defend their best interests, to comfort them.
What I love best about pediatric oncology nursing is working with an amazing cadre of caring, giving individuals. This includes my nurse colleagues, as well as all the disciplines of this team, and as well as with the patients and their families.
Работе медсестрой детской онкологии больше всего я люблю проводить время с родными людьми.
Being a pediatric oncologist means anything for me. It's not only my job, it's my dedication for life.
My proudest moment as pediatric oncology nurses, be an engaged nurse with that profession. If I had the possibility of reborn, no doubt, I choose nursing pediatric oncology.
I was not to the pediatric oncology nurses, when I bring that smile on a child's face, the family and the working team. Pediatric oncology nursing has taught me so much. It's taught me to listen to children and families, stories they tell, and to hear the questions that they ask. It's taught me to be honest, to be open, to be brave. It's taught me to listen to the nurses I work with, to hear their concerns, to learn from them. It's taught me to be kind. It's taught me how lucky I am to live in a country where all children get the treatment that they need, and to have a responsibility to advocate for children and for colleagues in places in the world where that's not the case.
My proudest moment as a pediatric oncology nurse is when the whole cancer team is working together to support the patient and family.
Pediatric oncology nursing has taught me to be hopeful despite the many situations and be always grateful for the gift of life.
And in the words of Gabo, who you may recognize from the How I Live video, who has been one of our spokespersons for the Global Initiative, he said, as children, we are not only the future, but also the present of this world. Our future depends on the adults of today. Thank you very much. Any questions? I guess we'll open it up. Okay. Oh, Dr. Lampier.
So, and beautiful presentation. Thank you so much. I'm just wondering in terms of like getting from the 30 to the 60%, and nursing is a critical piece, but what else is being done to get there?
So the early diagnosis campaigns, that is one of the largest initiatives that's going on across Latin America and other regions. And then also essential medicines. So there's a group, the WHO is working with IARC, St. Jude Global, and many others to help to source kind of a community kind of pot, if you will, for lack of a better word, of essential medicines for childhood cancer. Oftentimes, the quality of medications and medicines are inconsistent, which of course affects survival rates. And then also they might stock out. So there's an inconsistent supply of these medicines within different countries. So sometimes physicians will have to select patients who can receive the full course of treatment. And so, you know, they triage the patients that they can treat fully. Yeah, so those are two main initiatives that are going on. Thank you. Oh, Dr. Markaki.
Great work for me, and it has been a fascinating journey, and listening to this is really great to see, you know, the evolution of the work. So pediatric oncology, I think in my mind, is a prime example of needing to balance the high-tech know-how with the high-touch know-how. So can you speak to that, and especially, you know, the work that your group has been doing in the low resource countries? How do you balance, you know, the needs for a high-tech approach with the needs for the high-touch approach, and you know, maybe speak about the guidelines and how that balance is achieved through that?
Well, I would say, you know, the majority of treatment protocols in resource limited settings are adapted from other widely used childhood cancer protocols like the Children's Oncology Group, BFM in Europe. So they are lower dose, you know, concentrated chemotherapy that's given to patients. Oftentimes, they will not have access to radiotherapy in certain countries. So I would say the high-tech approach really depends on the level of capacity within the country for treating childhood cancer. Do they have a referral network? Do they have a tertiary care center that can care for children with cancer? So children can receive care in different settings, you know, in primary care, more community settings for lower risk. And then it goes up to secondary or tertiary and referral centers based on the type of care that's required. So balancing that, how do you get the resources? So I had mentioned in my presentation, you know, working with international partners who can help raise awareness, kind of help support identifying priorities, speaking with governments along with the local leaders as an advocate and a partner. Also, you know, it's really the government that needs to step up in providing these resources. And so in many cancer control plans, that's also something that's a priority within the global initiative, is to include childhood cancer in cancer control. So oftentimes they're not included. And then within childhood cancer, it might just be a couple of lines about, you know, training nurses and doctors. But talking about essential medicines, like in the Philippines, the Department of Health is actually funding packages that have been developed for ALL so that they are making sure they're preparing the right drugs, the supportive medications that are needed to treat a child with cancer. So those kind of governmental partnerships, along with the NGO and the experts, subject matter experts, is really essential, I think, for long-term change to really make an impact. Now, the high touch, we talk about palliative care, because there is such a delayed diagnosis because we're lacking early diagnosis programs and recognition within the community expertise from, you know, primary care workers to identify that this is childhood cancer in a timely fashion. So I'd say palliative care is a huge priority everywhere you go, across every level of care in the community. And oftentimes childhood cancer isn't even diagnosed. You know, it's masked as something else. They might think it's an infectious disease, you know, and the child might die from infection, but it could be an underlying, you know, neoplasm. So that's something that we're struggling with. We don't actually know the true number of kids with cancer because oftentimes they're not diagnosed. We're just going off of estimated models. But palliative care is that high touch area. It's a huge priority, working again with governments to establish access to morphine equivalent pain medications, you know, education campaigns about pain medications, about morphine, because there is such a fear due to the opioid crisis in the United States, as I'm sure everyone's aware, internationally, you know, that has kind of had a negative ripple effect for people who were opening up to receiving those medications, and they're essential. Children, you know, everyone deserves pain management and to die without suffering. And again, palliative care is not just the end of life care, and I think oftentimes that's something that is a misconception. Palliative care is not equivalent to death. Palliative care is an added layer of support. We have palliative care within the hospital settings to help support our patients when they need additional layers of psychosocial support, emotional support, symptom management that the primary team is not comfortable providing, or maybe it's trained in providing. And so those are additional interventions for that high touch care. For nursing, I think every nurse needs to be trained, right, in the specialty. And in order to have good quality care, we need to have nurses who are dedicated within pediatric oncology and are not rotated. So that's another conversation with hospital administrators, at times with governments, if they have a national rotation system. So we're working on that. But, you know, nurses need to specialize. They need to be able to build their skills and competency in order to provide safe quality care for children with cancer. And that's what any of us would want for any of our family members, you know, and ourselves, if we were in a similar situation. So it's a scary time, and they need you know, people who can help them through it well. I hope that answered your question. Okay.
Nice.
Oh. Okay. Okay, yeah, no, go ahead.
Thank you so much for the presentation. I think you articulated really well, like the impact that the specialization will have on patient care. So my question for you is one of the, barriers like the limitation to, specialization, specifically in pediatric oncology. I think it was mentioned that understaffing of the hospitals or, nursing population, which is less than 3 per 1,000 of the population, can lead to past shifting and other barriers to specialization. So I'm wondering, like, are there any workarounds for that? Because that, my experience with the Indian healthcare system too, I feel that sheer population might pose a significant barrier to specialization. So I'm just wondering, are there any solutions to that particular barrier?
Yeah, that's a great question. And first and foremost, you need a nurse or a healthcare worker that wants to be there. You know, who's passionate about being there. So having them, be given the ability to select where they want to specialize, where they want to work is essential first and foremost. That's what's going to get them there and keep them there ultimately and hopefully. So that's the passion piece and the drive. And many people in pediatric oncology, they feel like it's their calling. So I would say some of the strategies for overcoming kind of the limited nursing staff within settings and the rotation of them out of pediatric oncology is really starting kind of small. So some of the strategies that have been used, for example, in Zimbabwe, going to the hospital administrators, most of the nurses rotate through, but talking with the hospital administrators and asking for 1 or 2 nurses to be specialized. Send them off for training somewhere, that has a training program. And then they come back and that's valued by the hospital administrators, especially if it's linked with some sort of, certificate or some endorsement of a credible kind of educational organization. So that would be the first step, is kind of starting there. And then, working with the hospital administrators, again, the thing we recognize we have limited staffing. But trying to build up, and also trying to build up the specialized staff, but also utilizing supportive care workers. So unlicensed health professionals is very important because oftentimes, nurses are doing total patient care. And their time is being spent on administrative duties or things that could be done by someone else, right? And so that's also working with hospital administrators and kind of introducing that concept or through educational care. Yeah, hopefully, did that answer your question? Okay, thanks. That's just one strategy. There are many, of course, tailored to different situations. Yeah.
In one of your slides, it appears most of the hotspots are Central America, Africa, Europe, but it looked like there was one hotspot somewhere in the southeast region of the United States.
Okay, let me look. And you're talking about specifically with it was towards the, where was it? Sorry.
Toward the end. I wonder if it's St. Jude's Hospital.
Was it this with our programs?
Maybe that's it. Yeah, looks like there was a, I can't see it now.
Oops. Okay.
Yeah, is that us?
No, that's St. Jude. Yeah, so this is the regions and countries where we had educational initiatives and other initiatives that we were working on.
It's a good kind of hospital.
Yeah, exactly. Yes, but of course, within countries, there is disparity, you know, in access to care, as we all know. And so that does impact, the delayed diagnosis severely and abandonment, as we saw in the How I Live video. So even if the nation has made great strides, at an aggregate national level of reporting, we know that we need to dial down, to different districts as well. Yeah, to identify those areas really needing help, to help improve those referral pathways.
So could you speak a little bit to the, like the community awareness program, or maybe even how you are using victims here, the children, other than for advocacy? Like, for example, in my field, in HIV, of course, we are working with adults, but we use peer mentors. Are there any programs like that? Where, I don't know, a child helps another child with disclosure of their diagnosis and processing, and just going like a body treatment, so treatment body.
You know, I am not an expert in that area, but I think Dr. Landier may know.
It's okay, yes, I'm just wondering from my field, you know, how that translates.
Right. So it's more parent to parent, not so much child to child. But it's that, because the parents really are the ones, you know, responsible for the kids and guiding the kids through the process. And so the parents getting that peer support is critical. So maybe that's how it translates as far as compared to your population, is the parents helping each other.
Thank you.
Oh, sorry, that was very slow. So, and another question, if I can, just for our students and other people listening, how can a non-nurse professional get involved in your activities and help with your activities?
Wonderful. Well, if you're interested in getting involved, I mean, I think there are lots of opportunities. Just it depends on what you want to do, right? Where your interests are. Early campaigns, early recognition campaigns. There's a lot of opportunity for creating educational materials for the global initiative. If you're interested in that, come let me know and I can connect you. And then I would say, you know, just learning more too. Start attending some presentations on, you know, childhood cancer in the global initiative. Yeah, and then kind of, I guess that's it, to start, yeah.
To start.
To start the
People
conversation.
clear.
Yeah.
Participants. Rachel, I think we do not have any questions. Anyone from here, any more questions?
In terms of like staffing and then specialization, how does that change in the case of COVID? I know that there's been a lot of burnout in the US healthcare system. Have you seen that in other places, and how does that affect the work?
We don't have the data on that yet, although I know a study was recently done in Australia by a colleague, and so they will be presenting those results soon. Now, just, you know, through conversations with people, it's been, you know, challenging. I've been out of the clinical area again. Here are clinical expertise, clinical experts who are in the field right now. But yeah, I mean, it's been a strain on health workers everywhere. I think in pediatrics in general, because COVID didn't affect, you know, children as heavily, the stress and strain was more related to them being pulled out of staffing due to family obligations, getting sick themselves, you know, caring for their children, having to make those decisions across the board. Their was a lot of, shifting and in policies and procedures and the ways of operating in hospitals all over the world. And that really caused a strain on health workers. And as you know, a distrust, with leadership and in some areas where they felt unsupported. And I think that kind of crosses over to some work I've done with Dr. Patrician with Alabama nurses, looking there too, but it's the same across the world. Everyone was experiencing similar issues with nurse staffing. Obviously, if you're in a country where you have less health workers, they're feeling it even more. And so then you can imagine just the care quality goes down. But I think a lot of our nurses have stayed with it. And there's, programs that are going on. People are looking at burnout across the world and interventions to be able to help support the health workforce. Hopefully to rejuvenate and continue on and also train up new workers, right, who will be coming into the workforce. So it's definitely a crisis all over the world. But again, for pediatric oncology nurses, oftentimes they're there because they really feel like this is where they're meant to be. And they want to stick it out. So we just need to help support them. Yeah. Oh, Dr. Lindier.
Well, I just had a comment because it links back to Dr. McCarthy's comment about the high touch. One of the most stressful things in pediatric oncology during the height of COVID was not being able to touch families, especially you're delivering a diagnosis to a family. Physicians were talking about how they couldn't even hug the parent or sit with them and hold their hand, or the things that they just naturally do. And the nurses, of course, are always there afterwards to do that as well, to support the family. And it's very high touch, and there's lots of tears, and there's lots of kind of exchange of just the human element there that could not be done. And everybody was in their full PPE and then staying 6 feet away, and all those things are very stressful. So I think that added a layer to it as well. And I think there's a lot of relief in terms of feeling like you can break those boundaries now a bit and have those kind of situations where you actually can reach out and touch people again.
Wonderful. Thank you.
Yeah.
Well, thank you to all of you nurses in the room who are doing that. So again, so you have our full appreciation and admiration.
Yeah, I just one last question, sorry.
Yeah,
I'm just curious, besides St. Jude, who are the major global donors for this initiative? I mean, I know WHO UN is putting a lot of attention on it, but what entities are the primary? Yeah.
For the WHO initiative?
Well, yes, but generally for pediatric oncology, putting forth this effort, I mean, behind the WHO, I feel like it's a bit all connected, but are there, like besides government agencies, are there any particular other private donors or philanthropy that this is their dedicated cause, or this is their particular initiative right now?
I'm not aware of any. I know that there are people working kind of in parallel, in alignment with the initiative, getting grant funding, working on projects. There are a lot of kind of actors who are involved in supporting program development internationally. Now, as far as the WHO initiative itself, I mean, I know St. Jude is the primary funder and has invested $200 million into the initiative. So that is really kind of driving it and continuing to. But I am hopeful, and there probably are other contributors that I'm just not aware of. Yeah.
looks like we're out of time, but thank you so much for being here. today. And thank you to our virtual participants too. This will be available on our YouTube channel.
Thank you so much.